Good afternoon and welcome to our Women's and Infants Lectures series. I am Dr. Rogelio Rivas, Corporate Vice President of Baptist Health International. It's my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A feature located at the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Rafael Perez and Dr. Adam Geronemus. They will be presenting a lecture titled Diagnosis and Treatment of Uterine Fibroids, a Multispecialty Approach. Our first presenter is Dr. Rafael Perez, who specializes in obstetrics and gynecology at Baptist Health South Florida, and is the medical director for the Pelvic, Incontinence Testing and Fibroid Center at South Miami Hospital. He is double board certified in obstetrics and gynecology and urogynecology. Dr. Perez received his medical training at the University of Puerto Rico School of Medicine in San Juan. He completed his residency at Johns Hopkins affiliated Greater Baltimore Medical Center in Maryland. Dr. Perez has extensive experience in minimally invasive laparoscopic and robotic surgery. He helps women of all ages enjoy optimal health with procedures, treatments, and screenings designed to address a broad array of gynecological and obstetrical issues, including menopause, infertility, incontinence, pelvic organ prolapse, and endometriosis, offering advanced minimally invasive procedures options like FemLift for vaginal dryness and vaginal atrophy, and robotic assisted surgery using the cutting-edge Da Vinci surgical system. In addition, he provides routine and specialized cancer screening services for breast cancer, cervical cancer, and ovarian cancer. Dr. Perez is a fellow of the College of Obstetricians and Gynecologists and one of the original members of the South Miami Hospital Committee for Robotic Surgery as chairman of the Fibroid Center of South Miami Hospital. Dr. Perez is also a board member of both South Miami Ambulatory Surgical Center, MASC, and the Center for Women and Infants at South Miami Hospital. He is also a member of the American Association of Gynecologic Laparoscopists and American Urogynecologic Society. He trained under two of the most influential doctors in their respective fields, Dr. James Dorsey for laparoscopic surgery and Dr. Alf Bent for urogynecology. Dr. Perez has been a preceptor at laparoscopic courses in Maryland and Florida. He is part of the teaching faculty at IMET, a company specializing in teaching courses in advanced gynecological laparoscopic surgery and vaginal reconstructive surgery to physicians wanting to learn new procedures. He also participated in a course sponsored by the American Association of Gynecologic Laparoscopists to teach medical residents in training skills for laparoscopy and hysteroscopy. Dr. Perez is fluent in both English and Spanish. Our second presenter is Dr. Adam Geronemus, a vascular and interventional radiologist at the Miami Cardiac and Vascular Institute and Associate Medical Director of the Fibroid Center at South Miami Hospital, both part of the Baptist Health South Florida system. He is board certified in diagnostic radiology with a certificate of added qualification in vascular and interventional radiology. Dr. Geronemus received his medical training at the University of South Florida College of Medicine in Tampa, where he also served a transitional internship and a residency in diagnostic radiology. He then completed a fellowship in vascular and interventional radiology at the Miami Cardiac and Vascular Institute. Prior to this, Dr. Geronemus obtained an undergraduate degree in biology at Indiana University in Bloomington, Indiana. Dr. Geronemus is an associate clinical professor and vice chairman of the Department of Interventional Radiology at the FIU Herbert Wertheim College of Medicine. He currently serves as program director for the world-renowned International Symposium on Endovascular Therapy, ISET. In addition, he is program director for the Symposium on Clinical Interventional Oncology, CIO. Dr. Geronemus has published journal articles and lectured at national and international conferences in his areas of interest, including minimally invasive treatment of uterine fibroids, uterine fibroid embolization, and minimally invasive interventional oncological procedures. He is an active member of the American Medical Association, the Radiological Society of North America, the American Röntgen Ray Society, and the Society of Interventional Radiology. Please let's give a warm welcome to Dr. Perez and Dr. Geronemus. Dr. Perez?
Hi, thank you again for that wonderful introduction. I know we're having a busy day today, and I'm going to get into some slides that's going to help me guide everybody who's watching through what we do here at South Miami in the Fibroid Center, and then we'll talk a little bit more about incontinence as well. Let me start by sharing the screen with you guys. All right. So I'm going to take the first part of this. My partner in the Fibroid Center, which is Dr. Geronemus, as mentioned before, will talk a little bit more about his part in a short time. But I first wanted to go over some things that are crucial to understanding what we do here. And first of all is our mission statement. So we always believed that fibroids were like the orphan child of gynecology. Nobody wanted them, but they were so prevalent in the community. And what we wanted to do when we first started the Fibroid Center was to create one place in which we could offer everything in one location, sort of the one-stop shop, very convenient for the patient, but at the same time, very individualized. And this is where the collaboration between the interventional radiology arm and the gynecologic arm and also infertility came about, and this became the multispecialty approach. So we wanted to be the preeminent center, and through our data collection and fibroid registries and other things, we kept pace of what we were doing, and at the same time, we provided information back to the community as to what it was best treatment, best practices, etc. First of all, this is, when I say the orphan child, it's funny because this is a very common problem. I mean, 50% of women of ages 35 to 49 will have fibroids. Of course, none of them are, all of them are symptomatic, but it is a concern when they're found to patients. A lot of times at the Fibroid Center, we have people to come and contact us because they have fibroids, but really don't have any other problems. And the reassurance is that this is normal, this is something that needs to be followed, but nothing that needs to be addressed in any other fashion other than follow-up. We have an incidence that's greater in the African-American population here in Miami. We do see a lot of patients, both also Hispanic, of course, and we see also a slight increase in that. Hispanic population is more in the prolapse, which I will talk more at the end. So irregular bleeding is usually what prompts patients to contact the gynecologist, which then usually do some imaging testing and finds out, as you can see on the little image on the bottom right there, fibers can be in multiple locations. They can be pedunculated, they can be intracavitary or submucosal, or in the muscle of the uterus. They create a larger cavity or a cavity that has more blood flow to it, and therefore that creates heavy bleeding. So a lot of the times this is what most patients present with. Now, some patients present with pelvic pain, and some of that is related to those fibers that are big enough to put pressure on the organs in the pelvis. And if they're big enough, they can even put pressure on the organs in the upper abdomen as well. But other symptoms that come with this because of the size of the uterus that have fibroids are painful intercourse, painful periods because of not only the heavy bleeding, but also the amount of inflammation that's created by the heavy bleeding. Urinary symptoms, this is similar to when patients are pregnant. They put pressure on that bladder, they feel that they need to go constantly. And the same thing happens with the rectum and the rectosigmoid, there's constipation. Infertility in those patients who have fibroids that attack the cavity, and recurrent pregnancy loss, the same thing. So we can see that this creates an array of different conditions that are going to be encountered by the gynecologist on a daily basis. The imaging that we normally use initially, it's usually transvaginal. And the reason for that, it's available in the doctor's office, it's available everywhere. It's fairly cost effective. The main problem with the ultrasounds is that the reproducibility of where the fibroids are, the location and the size is not always as good. For those patients that need to be assessed in the cavity, this is mostly the infertility patients, there's something called sonohystograms, which are a fluid that gets pressed into the cavity and then use an ultrasound to sort of look for polyps and fibroids that are inside the cavity. At the Fibroid Center, we definitely use MRI. And why is that? Well, one of the main reasons I use it from the gynecological point of view is that it gives me a tremendous map of the uterus and where the fibroids are. So when I'm in surgery, I can look at that MRI image and find out where I need to make my incisions. It makes my surgery a lot more efficient. And at the same time, I don't miss the smaller fibroids that otherwise would be hard to pick up. There are some other methods of doing that, like intraoperative ultrasonography, but it is harder to do. And sometimes it is not as conclusive as having a picture of the MRI. The second reason, actually the most important reason for Dr. Geronemus, is that we see what kind of blood flow, because we do it with and without contrast, these fibroids have. Knowing what the blood flow has tells Dr. Geronemus whether they're candidates for the interventional radiology procedures such as uterine fibroid embolization. Finally, there's a way we can look inside the cavity, different from the sonohysterogram. This is actually in the office. We can look with a small telescope up the vagina into the uterus called a hysteroscope, and that shows us in a live setting how these fibroids are inside the cavity, but it doesn't tell us anything about the ones that are outside. So these are the most important modalities that we use. So when we compare the ultrasound and the MRI, we can now see some of the things that I was talking about. It does look well for the fibroid size and location, but not as well as the MRI. And the main problem lies when you have really big fibroids like the ones we usually treat here. The pelvic ultrasound doesn't quite cover the whole fibroid. So you have to do both pelvic and abdominal. And then you lose some of the sensitivity of picking up how well these fibroids are and where they are. For the MRI, they're important because we, as I said before, we know how much is the fibroid, where they're located, but more importantly, enhancement. And then for us, we like to treat, we always obtain ultrasound MRIs for the UFE patients after they've had the uterine fibroid embolization, because that way we can actually know that it was successful and at the same time that there's no other problems. The MRI also gives us the idea that if we see anything in the imaging that it is concerning for cancer, then that would give us a different approach. This is not the most common, but in some patients, it makes us take a different surgical approach instead of minimally invasive, in which we have to cut up the fibroids, to an open procedure in which we're going to remove them in their entirety. But that's more detailed. Doppler evaluation can only be done with ultrasound. It shows us a little bit of the adnexal masses. This is more important for the ovaries than it is for fibroids. But again, we utilize both, but us in the Fibroid Center, most patients already have had ultrasounds, and we use the MRIs because they give us all the information that we need. In the treatment modalities, I'm not going to spend much time on the medications because most people who are on the call will probably know the majority. These are hormonal treatments such as birth control pills, high dose progesterone, and those are tailored mostly to the symptom of bleeding. They will not change the fibroids in any way, shape, or form, but the ability to, with a simple medication, treat the fibroids and or the bleeding caused by the fibroids sometimes is appreciated by the patient. Then, of course, there's the fibroid embolization, which I will talk a little bit later, and surgery. And in the surgery, we divide the surgical procedures into two. One that saves the fertility so the patient can have, these are usually patients that haven't had children. We remove the fibroids either hysteroscopically if they're inside the cavity in a certain size and position, or laparoscopically, which nowadays in our institution is mostly robotic. And I will get a little bit into that a little bit later. And then there's a hysterectomy or endometrial ablations. And I'm going to touch upon a little bit on the endometrial ablations, just the burning of the lining for patients who have fibroids and have heavy bleeding. This again is to address the bleeding without removing the uterus. And of course, robotic or laparoscopic hysterectomy. I'm going to quickly mention magnetic resonance guided focused ultrasound ablation. It is a very narrow application because it is only for fibroids that are smaller, and the patients cannot have had prior surgery, bowel in front of it. So it's basically heating them up with ultrasound using MR as a guide. It's a very long procedure. We have not used it in our center because of the of the limitations that it has. I think I lost. Did you guys lose my screen?
We're in treatment modalities, doctor.
Treatment modalities. Okay. So let me see. I'm back. Perfect. Thank you. So the medications again are the oral contraceptives. There's GnRH agonists and other medications that go against the receptors for progesterone. And all these medications, some of them are available in South America and the Caribbean. In the US, not all of them are available. I do have patients that bring it from those countries, and they're very good. But the problem with most of these medications, and you can see the list there, is that they only work when they're given, and a lot of them have a lot of side effects. So up till now, we're still looking at basically either blocking the hormones at the fibroid level or making the ovaries not produce the hormones, and then they shrink. But the moment you take that, it's just sort of like a brake in a car. It stops them from growing or makes them shrink. But the moment you release the brake, they come back again. So we look at medication sometimes as something in between to tie the patient over until we're ready to do more definite procedures. The fibroembolization, and I'll let Dr. Geronemus talk a little bit about this later. We find this is a procedure in which a small arterial catheter is passed through the large vessels into the vessels of the uterus, and then some small pellets that are triglyceride pellets are placed so that the fibroids absorb them into their small vasculature, and then they block the vasculature and the fibroids die because of lack of oxygen. And it takes a little bit of time. It's a fantastic procedure that was started around 1996, more or less. And again, I'll let him talk a little bit more about that in a moment. You can see some of that, and this is some of the uterine fibroembolization. Again, I'm going to let him talk a little bit more about that in a moment. I'm a gynecologist, so I'm talking about hysteroscopic myomectomy, and this is a little bit of data on the long-term effectiveness of these treatments. These are older studies, and there have been some newer ones in patients who did this at a 6-year follow and 9-year follow-up. You could see that the numbers of people who did not need any further surgery for the bleeding and for the fibroids are high, 83.9 and 91.3 on this Carvello study published in 1998. And the symptomatic improvement was 2/3 of the patients, and then only a small percentage needed about another procedure. So this is very reassuring data in that if we have fibroids that are located inside the uterus, somebody who has the ability to do hysteroscopic myomectomy will be very successful in controlling their symptoms and their recurrence. In pregnancy rates after polypectomies and myomectomies, all polypectomies increase the pregnancy rates once the cavity was normal. And in those patients who have fibroids that were more than 2 centimeters, the pregnancy live birth rate was increased significantly. But it's important to know that there was no difference in spontaneous abortion rates. And that's important because a lot of people were worried that when we went inside the cavity and provided some surgery in there, we could create some scar tissue that would inhibit the pregnancies from latching onto the endometrium, and that was proven not to be the case. Again, this data 1999, but still very prevalent because it had a lot of patients. Laparoscopic myomectomy was the initial way we started, and this was before the Da Vinci platform. And then there was several studies in which that the abdominal approach was completely contrasted with the laparoscopic method. And then the laparoscopic method was, less blood loss, less post-op pain, shorter recovery, everything that we now know. These are studies from 2007. It was basically a way of the doctors, gynecologists that were beginning to do more myomectomies because they were a little bit harder to do on the straight laparoscopy, to prove that they were wonderful. But if you look at the first line, it says longer to perform, which was always something that they had against the laparoscopic myomectomy. But given all the other good things, people began to do them more often. Then came the robot, and this was in 2005. It was approved for gynecological use. And then we began to see studies that compare not only the robotic myomectomy, but the conventional laparoscopy. And then they found that there was even less blood loss, less complication rates, and the length of stay was even less. And there was no difference in the operating time. So the robot gave you the ability to do the same surgery in the same time, but with less complications. And that's what we use now. So there was several, all the studies that, we went ahead and quoted with laparoscopic hysterectomy, and this included both laparoscopic, vaginal, and this is for hysterectomies. And again, longer operating times. In the studies of laparoscopy for hysterectomies, there was more urinary tract injuries. This is for the ureters, about 1 or 2%. So compared to abdominal and vaginal, and that's just because of the technique. And a lot of this has to do, this was 2006 when it was published, but had to do with the technique was harder to do. Again, as a robot began to be in there, it was a lot easier to do these procedures. So the laparoscopic hysterectomies versus the vaginal ones, they were all similar outcomes in terms of bleeding, post-op length of stay, but the operating time was longer, laparoscopic for about 41 minutes, which was significant for those cases that could have been done vaginal. In robotics and laparoscopic, when compared, there was no difference in the studies. Comparing just conventional laparoscopy and robot-assisted laparoscopy. Now, what did happen in the studies was that the most difficult cases that before, for example, before laparoscopic myomectomy, a size of 5 to 6 centimeters was considered large for fibroid. For something in robotics, we're looking at 10, 12 cent. So we were able to do cases that before we weren't able to do it, and the patients who were now given that opportunity to enjoy the benefits of laparoscopic surgery with more pathology. Endometrial ablation, I'm just going to mention, this is again one of those procedures that we do in those patients that do not want any fertility. The Janssen study went over, this is in Sweden, over 13,000 hysteroscopic procedures. Complication rate was very little, 0.38. And subsequent hysterectomy rates in about 3 to 5 years were anywhere from 9 to 24%. So the majority of people, up to 3/4 of the people who underwent endometrial ablation, didn't need any more surgery. And when the success rate was, divided into patients who never had another period, which of course were the happiest campers, then it was 50% of them, and then 35% had acceptable bleeding, which means that it was reduced to a point that it was not creating the problems. Again, this is for patients that do not want fertility. Fibroids and fertility, a little bit is that we see, again, fibroids are very common in population. So when we say 1 in 4 infertile women, this is probably the background rate of fibroids in the population. But once you are older, and a lot of the infertile women that were going to the clinics that these studies were published from were a little bit older, they had more fibroids. Therefore, we began to see that there's an association between the fibroids and the actual fertility. There's a quote from one of the studies that 50% of women with unexplained infertility, meaning that we couldn't find any reason for it, after they did myomectomies, they were conceiving. So again, we don't know, again, reducing the fibroids improves the cumulative pregnancy rates. The submucosal fibroids reduce the ongoing, so that's why we like to take them out. And any fibroids in the patient will increase the odds of the baby being in a breech presentation or oblique. Cesarean delivery is also increase, and so is preterm delivery. So a lot of times we can fix these problems before we try. It depends on, again, like we said at the beginning of the talk, of what it is, what the patient desires. So we don't know why they interfere with fertility, but we think it has to do with the uterine contractility, elongation or distortion of the uterine cavity, and reduce endometrial and uterine blood flow. But again, at this point, we don't really know. So So the next slide is a little bit of what we do at the Fibroid Center, and we put it up there because this is something that we honed over the years, and we think it works really, really well. There is a pre-consultation process flow, and that involves the patient contacting us or their doctors and sending it to us, and then there's a coordination through the demographics, and our nurse practitioner comes in, and there's some screening questionnaires, which is something that we use for our data tracking, and then the appointments are provided. And then what we try to do is, depending on where the patient's coming from, we always give them an appointment that's related to what they need to talk. So in general, for us, Dr. Geronemus and I always are present. So they get the benefit of having two doctors at the same time that come from different fields, but that we've been working together so long that we now, basically we can end each other's sentences. But the beauty of that is that we can discuss in front of the patients the same things that other doctors would need several appointments to do at the same time. And that's what's created the Fibroid Center to be so successful in treating a lot of patients that in other places would not have been given a second chance as to what to be done with them. So the day of consultation, they come in and they see both of us. We have the MRI results. We do show them to them on the computer so they can actually understand their pathology. And then Dr. Geronemus goes in detail about what happens with the imaging, and then he goes into his part of the options that we have for the patients that have that. So we have, again, the same day consultation with 2 or more specialists. We also have access to the infertility specialists if we need them, oncologists as well, if there's any issues for cancer. We always give exit recommendations based on the consensus opinion. So it's not like you go one place and then have to go another, and then you get competing. At the end of the day, Dr. Geronemus and I, or the infertility, we say, well, this is the best 2 options, or this is the best 3 options, or you have all options available to you. And that's, or you need nothing. And that's great because the patient really feels comfortable that these recommendations are the final things for which they have to pick or choose. And then we contact the patient's doctors if they've been referred to us. Let's see. And this is our team: gynecological surgeons, interventional radiologists, reproductive endocrinologists, and the radiologists are all part of our team. These are our pictures. Dr. Geronemus is here, so I'm going to backtrack to the UFE slides so he can talk a little bit more about that and other things. And then we'll come in at the end, and I'll talk a little bit about, yeah, there we go. These are yours. I leave you with my partner in crime here at the Fibroid Center, Dr. Geronemus.
Thank you, Rafael. That was great. And sorry that I'm late. I see you there, Roger. This is how are you doing? Sorry, we were dealing with an emergency upstairs. But like Rafael said, we could finish each other's sentences, and we represent each other very well. This is not only our jobs, but the Fibroid Center for both Rafael and myself is a passion. We love giving this what we consider excellent care, way above the standard of care, and giving patients all the options and the information that they need. So I'm a vascular and interventional radiologist, which we basically do everything. We consider ourselves problem solvers, but I specialize in women's health and vascular procedures. And uterine fibroid embolization is really treating uterine fibroids, what we say, sort of from the inside out. We attack them using the vascular supply. What we do is, this is a totally minimally invasive treatment where we go in through the arteries. Now we go mostly through the left radial artery, sometimes through the femoral artery, and we're treating the arterial supplies. They stay in the hospital only, overnight. Some do go home the same day, but we keep them for pain control, and hydration. This procedure has been done since 1995. Actually started in France, and now it's been done in the United States since 1997, and here in Miami since 1997. This is not an experimental procedure. It's well validated. Our first registry was over 3,000 studies, and since then there's been multiple randomized, controlled prospective studies. And this is just showing the procedure actually from the femoral artery here, and it shows us accessing the femoral artery. We go up, and then we come down into the anterior division or hypogastric artery, And then with a small catheter, we go into the uterine artery, past any branches down to the lower uterine segment or vagina, and we get really close to the fibroids and we see their blood supply. And this is just showing the images. These are the what we call hypervascularity or neovascularity, which you get with the tumors or benign tumors, malignant tumors. They demand more blood supply. So the arteries actually grow out of control, and we selectively embolize them, that's a fancy term for blocking them. And we take away all those abnormal vessels that you're seeing here. And this is what it looks like afterwards. It's what we call pruning of the neovascularity or the tumor vascularity. What that does is it causes these fibroids to shrink in volume. We get about a 50 to 60% reduction in the volume of the fibroids themselves, which gives you a reduction of the uterus itself by about a 40 to 50% volume. So with bulk symptoms, when we talk about fibroids, we break them down to bulk symptoms and bleeding. The bulk symptoms are the painful intercourse, the back pain, the frequent urination, the constipation, the bloating. That we're about 88 to 92% successful in, and that we get from that decrease in size. The reason why it's 88 to 92 is because there's many other things that cause those symptoms, such as back pain. And unfortunately, with the bulk symptoms, we don't know it really until we treat. The MRI gives us a lot of information, but we really don't know until we treat and see that decrease. And that decrease does happen over time. The greatest rate is within the first 3 to 6 months, but it continues to shrink over the next 2 to 3 years, actually. The abnormal uterine bleeding, this is showing greater than 90% in we study our patients here very closely with a quality of life score. And here we're greater than 97% successful in bringing the menstrual bleeding to the point where the patient is completely satisfied. And then this is already presented on this. And so it's really a great procedure. At first, when we first started doing uterine fibroid embolization, there were questions about fertility. The original data and stuff published out there said, don't have this procedure if you want to have children. We've had several patients after fibroid embolization have children. In many countries, such as France, it's actually done as a treatment for infertility. I do firmly believe in my heart of hearts that it will be a treatment in the United States for infertility, not the treatment, because there's many things that go into infertility. But by decreasing, as Rafael said, what is the mechanism of fibroids and infertility? We really don't know, but it can be part of the bulk and the contractility, which making these smaller does certainly help. We really have had great long-term success. We follow our patients very, very closely here, and our patient satisfaction is extremely high. And again, now we do these mostly from the radial artery, which even shortens the recovery. The only recovery for this procedure is really how you feel. So you have a little wristband on for 2 hours, that comes off. We give you IV fluids and pain medication. In my meantime, back to work is about 5 to 6 days, but you're only really limited to how you feel. And yeah, and we do all, and so, here, because of the fact that, and we're talking to each other as we do in the consultations, we're able to do some fibroids, whether it's embolization or myomectomy here in the Fibroid Center, that other people won't do because of size or challenging anatomy, because we have the backup. I have the backup of Rafael. Rafael has the backup of me. So even if he sees a uterus that he thinks is too vascular, sometimes we'll embolize it prior to hysterectomy or myomectomy, either to make it smaller or decrease the blood supply. Sometimes I'll see a patient that has multiple fibroids, and then they have one small fibroid in the cavity, and she'll really do much better if that one fibroid is removed hysteroscopically, which is a same-day go-home procedure. Has that done, we give her a little bit of time just to recover at home, even though there's no significant recovery from that procedure. And then we proceed with uterine fibroid embolization. So by working together as closely as Rafael and I work together hand in hand, we have so many more options that we really, we think that drastically increases the success rate, both technically, clinically, and also from a patient satisfaction, how they feel about themselves, the procedure, and their experience in getting the procedure done.
You go, see if you can go to because the rest is just a team, and you can do, keep going on throughout those.
So we're going back through fibroids and fertility.
Keep going.
So we did this in the process of flow.
Yeah.
And
That's us, and
this is us. We've been doing this a long time. In this picture here, Rafael and myself were much younger. Even in this picture, we were much younger. This is not a model. This is a true patient who was super satisfied.
yeah.
And we had both seen this patient, and she did great. What do we have after this? The physician team. This just shows that we have everybody. I think you went over this, right? With the gynecologic surgeons, interventional radiologists. This is our current team. The most important person is right here, Leanya, our nurse practitioner, who does all the pre-planning and helps us with the follow-up and scheduling, authorizations. I don't know, and Roger will get with us what's possible from an international standpoint, even with some remote consultations and telemedicine. But we would love to offer either second opinions, advice, help any which way that we can, even mentoring other physicians to help just get the best outcomes possible. I think, and then Dallas, I can't forget Dallas is our coordinator who does also, she's the, Leanya and Dallas are 1A and 1B and important people. And so she does all of our scheduling. She's has access to all of our calendars, our cell phones, get in touch. If you ever need to get in touch with us, just to talk, questions about patients or how to schedule a patient, if you call that number, she'll get myself or Rafael right on the phone. Other services offered here through the Center for Women and Infants is pelvic physical therapy for pelvic floor, pelvic health consultations. We have a very robust urodynamic program with urodynamic testing and treatment. And our patient care navigators are really special. They keep you in touch with the entire healthcare team. And once you're with us, we take care of everything. If you need a mammogram, we help get you scheduled. If you need an ultrasound, if you have other questions, it really is a concierge service offered, through the Center for Women and Infants, which is a center of excellence here at Baptist Health. That in many places you pay a significant amount of money for this service, and it's a free service that we offer to our patients here.
I think there's a urodynamic. Yeah,
you want to come and take this?
I'll go ahead and do a little bit. Thank you. So this is I won't not going to spend a lot of time on this, but there's same way we did the Fibroid Center. We've always had some pelvic health incontinence, not only testing for urodynamics, but we also believe the same way fibroids are very prevalent in the population. So is the incidence of prolapse and urinary incontinence in an older population. So we do, offer a lot of things that are the non-invasive methods, pelvic floor therapy and urodynamic testing to see exactly how we can help the patients. And then there's consultations for them. So this is a patient care navigator, and this is what we do in terms of doing that. I think that's it. If you have questions, you can now refer them to Roger, Rogelio, and we will be happy to answer any of them. We thank you for the opportunity of telling you what we've done here. We're super proud of doing this for 10 years plus, and we're very successful at it, and we're very proud of that. And I think it could help other people to know about us, and like Dr. Geronemus said, to be able to maybe learn some things from what we do, or at the same time share with their patients and do that. So we're gonna wait and see if I think I'm gonna kick it back to you.
Thank you so much, doctors. Dr. Geronemus, I'm glad you were able to join us. I know you were in a complicated procedure, and I appreciate you. You mentioned your coordinator and your nurse practitioner. Our international team deals with them, and they are a fantastic team. And as we know, any physician that needs to get in touch with you all, I mean, through Dr. Hakeem, myself, or the team, you all are always so readily available and eager to help us. And we always appreciate that. And yes, Dr. Geronemus, one of the silver linings to COVID is that everything now is possible via telemed. Back in the day, many insurance companies would not even cover it. And now we're living in a different world. And so, yes, we would love to do that. And as a follow-up to that, you know, historically, not many centers provide what you provide, right, doctor? It's either you know, especially in our countries, in Latin America, it's usually one approach. One doctor gives you an approach. And how long have you seen this change, kind of like almost like a tumor board, but this is a fibroid board or a infertility board, and it's like incredible for a patient to be able to get multiple opinions at one time. How long has this been happening, Doc?
You know, we've been doing this. I don't even know how long we've been at this for 12 years now. Wow. But there's, you know, you have to be careful because you know, we were the first, when we researched this very thoroughly, we were the first multidisciplinary fibroid center in the country. There were others that claimed it. There was one in it was Michigan, I think, that you would see a doctor at one office and then you would go to another office. And I don't know if Rafael went into this, but when we first started the Fibroid Center, our original plan was to have two offices next to each other where you would see one and then go see the other. But we decided, you know, at the beginning for the first month, we said, let's first see these patients together so we can learn what each other is going to say. But then we realized in doing it just for a month that one, it was fun and we enjoyed interacting with each other. Two, the patients were getting better care because there was nothing lost in translation. It wasn't a patient telling a doctor, well, this is what the other doctor said, or a doctor saying, okay, I'll call him and talk to him later. Also, as you see, we get pulled away. I was pulled away for an emergency earlier today, but Rafael, if I couldn't even come, Rafael could give my presentation as good as I could give it. And I feel confident that I could talk about myomectomy or hysterectomy as well as anybody can. And we really, you know, out there's a lot of centers that market themselves as fibroid centers, but they're really one specialty. There's not multidisciplinary. It'll be a gynecologic surgeon, an interventional radiologist. You could even get some, you know, vascular surgeons trying to do embolizations or gynecologists doing embolizations. That would be the equivalent of me trying to do a hysterectomy. And so we truly believe that the people who are best at what they're doing should be the ones doing that. And we give the absolute best patient care here.
And it's a lot of fun. And we've also, over the years, collected data. So it's not only for us, that was a big deal too. So we have data to back up what we're doing. And that makes all the difference in the world because we know we're doing better.
Doctor, and what I've seen, because I get to participate in your CWI meetings along with Dr. Hakim, the complication rates are so minimal when you come up with this approach, right, versus everything else. And did you see a change since you started that modality when you first started 10, 12 years ago?
Yeah, we've been doing this for a long time, and our complication rates are very small in terms, and that's because it comes from the expertise of having done many surgeries. So from the surgical point of view, procedures is something that if you do a lot, you get good at it. And if you're tracking yourself, you know what's you can't cheat. And that's the second part. So we feel that our complication rate that's why we get these challenging cases.
There was a question from somebody to all the panelists that said, what is the outcome for pregnancy in patients who have had fibroids removed through procedures that you have performed? You know, it's a hard question to answer because we've done so many, there's so many different procedures. And, you know, we have great follow-up, but we don't know once somebody gets pregnant, we don't definitely know. And so we really don't have that number. We know that, you know, if you go see an infertility specialist and you have any fibroids over 2 centimeters, they're going to tell you they need to be removed. That's not, I'm not saying they're right, they're wrong. That's not what everybody believes in, but that's certainly what that specialty believes in. We treat a lot of women with fibroids and there are successful pregnancies following this treatment. Having said that, over 40 to 50% of women have uterine fibroids. And one of the most common times to diagnose a uterine fibroid is during pregnancy, whether it's during a C-section or ultrasound during the prenatal period. So we really, Ravi, you couldn't put a number on the pregnancy success rate.
No, but we do know, for example, there's again, what we do here, we specialize on what the patient needs. And if you have a 12 centimeter fibroid, your pregnancy will be better if you have a myomectomy. You will be more likely to be pregnant and healthy. And I still do obstetrics, so I do my own myomectomies and then I end up delivering them. And I can tell you that the success rate is much better. So again, it's been, we understand that there's a relationship between fibroids and fertility. That's why I mentioned it. So if you can actually improve the way the uterus looks, and this, by the way, is also through embolization, we know that this patient has a better chance of being pregnant if that's what they want.
Thank you. There's another question that asked, do you typically consider oral treatments like Orion before surgical treatments? What are the pros and cons? I think you went over the fact of folks that have oral treatments and having to stay on them and then going off.
They're limited by the fact that once you stop them, you get back the symptoms. So it's a good stopgap for certain procedures. But we still don't know, for example, Oriana is a good question. We still don't know what happened with Lupron, which is similar to that. It's Egalocix. And they found that the planes or the way we shave off the fibroids and the capsules were not as good. It created more blood loss. So I haven't seen any data with Oriana. And in our case, a lot of times the people that we see here, the fibroids are so big and the bleeding is so much that it would not help them. Now, if somebody is not as sure whether this patient needs surgery, you can use some of this medication. And we tell them, we go through all the options, everybody who comes in here. We go from hormones to the most invasive option. And the idea is to find which one of the least invasive options is the one that fits the patient. But medications are there for a reason. I just don't think they're the final call.
And everybody's different, and each treatment is specifically tailored to each patient based upon their symptoms, how long they've had them, how disruptive their symptoms are. Do you have such bad anemia that you're having blood transfusions? That's an immediate, treatment needed. And then also their anatomy. Everybody has definitely, different anatomy. So no two people leave here with the same consultation and the same recommendations. There was a question from Belize that said, please briefly explain again the uterine fibroid embolization. So in simple terms, the word embolization is the disruption or blocking of blood supply in general. So we do it in traumas, we do it in anytime we want to take away the blood supply. Embolization of uterine fibroids is getting into the uterine arteries. We inject these tiny particles they're triacylglycerol. They're a sterile plastic or gelatin. They're permanent. They're smaller than a grain of sand or a grain of salt. And we're watching as we're administering these directly into the uterine artery. They preferentially flow to the fibroids, and we're blocking the blood supply to the fibroids. It's like squeezing your finger till it turns red and starts to throb. With that, when you take away the blood supply, you're starving them, you're strangling them. And just like we get the MRI pre-procedurally, we get one at 3 months follow-up, and we want to see those fibroids that they're dead. They have no enhancement, meaning they don't uptake contrast, they have no active blood supply, and that's what causes them to shrink. So the embolization is basically cutting off the blood supply to the fibroids. It's killing them. We're slowing the flow to the main uterine arteries because these uteruses become hypervascular in general. So there's too much blood supply, too much flow. And by decreasing that flow, by killing the fibroids, we really help restructure that menstrual cycle to the point where there's much less bleeding. It's usually shorter in duration and in the amount of blood loss during the cycle. So how many heavy days they're having, and their heavy days are not as heavy as they were before.
Thank you, doctor. There's a question that says, what would be your recommendation for someone who has twice had abdominal myomectomies and within 6 weeks post-surgery, the fibroids regrew? The shrinkage rate at menopause is minimal.
So with a patient like that, we would get an MRI. We would see, is there, so the ovaries still do secrete a low level of estrogen after menopause, and the fibroids are sensitive to estrogen. That's what keeps them alive. So if we do an MRI with contrast and we see there's still a robust blood supply to these fibroids, and then it depends on the symptoms. If they're just there, then it's not a problem. If there's postmenopausal bleeding, pain, urinary frequency in the uterus and the fibroids are enlarged, the patient might be a candidate for embolization. They might need a hysterectomy. There's all sorts of there's all sorts of different treatments possible. And that's what every single patient is a different answer and a different recommendation.
And a lot of people believe that just because they had abdominal myomectomies, we can't go in laparoscopically because of scar tissue, but that's what we do. These are the type of patients that they would send to us because somebody has tried twice. An abdominal myomectomy is a hard procedure. It's not everybody's cup of tea. People, the patients bleed a lot. So it gets to a point in that procedure that you might leave some fibroids behind, close the uterus to preserve the uterus, and then leave, and that's why the patient has the fibroids. But when you are able to control the bleeding, and I think laparoscopically we do that better than we do it open, then you can take out all of them. And if you have an MRI guiding you in the OR, like I said, that's why we get an MRI always, then I know where all these fibroids are and I don't miss them. So that's the combo of why we do what we do.
Thank you, doctor. And then there's another question that I think you already answered this, Dr. Perez, but just in case, does the location of fibroids in excess of 5 centimeters affect the probability of having a full-term pregnancy?
There's not, it depends where it is. If you have a 5 centimeter fibroid in the muscle of the uterus, what we call intramural location, probably is not going to affect you. But if it's inside the cavity or submucosally, meaning impinging on the cavity a lot, then that will probably inhibit. Normally, we tell patients that have fibroids and have no other symptoms that they can go ahead and try to get pregnant, because the majority of them do, and they do well. So why would we take out just because we know it's there? We don't do that. But if they're symptomatic, then we have to enter that discussion. And this is where the individualization comes. What do you want as a patient and what can we offer? And that's where this is a great marriage, because whatever they want, we can offer.
Thank you, doctor. And there's a question that also it says, has anybody ever, I guess, Dr. Geronemus, I think it's for you, has anybody ever reacted to the material used in embolization? And if so, what's the course of action taken?
So the answer to that is no. There's very few reactions that I've ever heard of. There's no significant reactions. This material that we're using now that's called Embospheres, at least 17 years, and it's an inert plastic with no reactions. It's the second iteration of it. The first iteration was a product called Embo Gold, where they put small flakes of gold in with the particles, which let us see it better when we're using fluoroscopy or real-time x-rays. There were some skin reactions and some mucosal reactions, like almost like a cellulitis, like an allergic reaction to that. So they took the gold out of it. And since they did that in the late 90s, early 2000s, there's been no reactions. We lost the volume on you, Roger.
Sorry, thank you. Can you elaborate on what is radio frequency ablation of fibroids?
Yes.
Yeah.
I could do that. There really is no radio frequency ablation. There's no there's high frequency ultrasound ablation, which is a combination of using ultrasound in MRI, and it ablates a tiny piece the size of a piece of rice in a couple of minutes. So it takes a ton of time to do anything. It is going through other structures, so it can cause damage to nerve and bladders. We do not do it here. About 10 years ago, we almost did a study with Philips, and they were looking at expanding that technology to do about a 2 centimeter size particle with each pulse. But the technology really never came around, and Philips aborted the project. It is offered at some outpatient specific centers. That's really done on a for-profit basis. I don't think it's covered by insurances. It's not something that we offer nor recommend.
And in case they're talking about radio frequency, in which little probes are placed into fibroids, either through hysteroscopy or in laparoscopy, myomectomy has been shown to be much better here.
Yeah.
If I'm going to do that radio frequency ablation of a fibroid, I would rather have them have a UFE, because it's better, much better.
We
you know.
treat a lot of things with radiofrequency ablation. We treat several types of kidney masses, liver masses, lung masses, bone lesions, because it is advantageous and it's a good therapy. Treating fibroids with thermal energy is not proven to be very effective.
Thank you, doctor. And there's a question from Belize. It reads, can you briefly explain again the uterine fibroid embolization? They're not aware because they're not sure that that procedure is done in Belize. But I guess the definition, doctor, is to be able to do IVR and to be able to do these procedures. So it's not available everywhere because usually you need more technique and time, correct? And training.
Yeah, and this is done mostly by interventional radiologists. And again, that's just the blocking of the blood supply to the fibroids. It is killing them from the inside out. And by taking away the blood supply, we're causing the fibroids to die down, shrink down. So we're decreasing the bulk symptoms. We're decreasing the vascularity and the blood supply to the uterus. And that's why we're successful at decreasing the menstrual cycle. So it's not like any specialty. We use our skills in other vascular disease, and we embolize also all types of benign and malignant tumors in other parts of the body. And it's the same catheters and wires and tools that we use to treat peripheral arterial disease that we use for this. And so it's just another application of our skill set. And it should be done by somebody with the right training and the right experience.
Well, doctors, I think we've hit the moment that obviously there's many questions to come, and we will be forwarding those questions to you. But I congratulate you. I know we all do, for everything you've been able to accomplish and the more to come. And so thank you for your time today. And on behalf of Baptist Health International, I would like to thank Dr. Perez and Dr. Geronemus for this informative presentation, and all of today's participants for your attendance. If you have any questions about today's presentations, please feel free to email them to us at bhiwebinars@baptisthealth.net, bhiwebinars@baptisthealth.net. We are proud to say that we make sure that they get answered. So please send us those emails if you have more questions. We look forward to seeing you at our next Women and Infants lecture series scheduled for August 11th, 2021. Thank you again and have a great afternoon.
Thank you, Roger.
Thank you.
Stay safe.